Psychiatric Manifestations of Seizure Disorders 2024. It's important for us as healthcare professionals to understand seizure-related disorders. And as I stated here, it's because of its stealthy and often missed presentation. What I mean by this is that if we don't look for it, we miss it. And if we miss it, it can lead to morbidity. So if we look at the essence of what epilepsy or seizure-related disorders are, it is the occurrence of repeated paroxysms of excessive uncontrolled discharges of neurons, leading to so-called epileptic seizures. These cause stereotypical disturbances of consciousness, emotions and behavior, motor functioning, sensory functioning, and autonomic functioning, which is subjected to the origin, speed, and extent of discharge. The prevalence across age groups of seizure-related disorders have bimodal distribution, and there is a peak with children and then again with older adults, with the highest incidence in those of 75 years and older. The risk factors in older adults are usually due to vascular brain changes. This accounts for about 50 to 70% of new onset seizure disorders, and it's usually due to either acute or chronic cerebrovascular diseases. Neurodegenerative diseases such as Alzheimer's disease, which has a tenfold increased risk of developing epilepsy or seizure-related disorders, as well as other neurocognitive conditions like Lewy body dementia or frontotemporal lobe dementia, or as dementia is now better known as major neurocognitive disorder. The clinical implications are important because if we don't recognize seizure, especially if they're focal or partial as it was known a while ago, we risk causing more morbidity. So seizure-related disorders or epilepsy is often missed because of its varying presentations. Seizures can present in diverse ways, such as subtle motor movements, altered consciousness, auras, etc., or non-convulsive states, often mistaken for psychiatric conditions. And we'll look into the details of these a little bit later. So why is this important? If we misdiagnose or miss these, the outcomes will be worse. So there will be more morbidity and we might give wrong treatments. Awareness among health professionals is crucial for accurate diagnosis and treatment. If we look at a brief history of seizure disorders or epilepsy, there was an ancient understanding which was often associated with either supernatural or spiritual causes. It was also in the Greek texts known as a sacred disease, and was often treated with rituals or spiritual interventions. With progression over time, like for instance in the 19th century, it was started to be understood as a neurological disorder, and by the 20th century, advances in neuroimaging and EEG improved diagnosis and understanding. In the modern era, we know that we developed anti-epileptic medications and also refined specific surgical techniques like Sperry et al. In the 1970s. Ongoing research into genetic and environmental factors continue. The classification of seizure disorders is quite important, as we will see in later slides. And this is done by the International League Against Epilepsy. So it is important to understand the difference between focal seizures and generalized seizures, as well as the difference in specific focal seizures, like for instance, simple partial seizures and complex partial seizures, which have now recently been renamed to focal onset aware seizures and focal onset impaired awareness seizures, respectively. So generalized seizures we understand as when someone falls down and they have the very specific motor symptoms, foaming at the mouth and so forth, and sometimes losing control over bladder and bowels. But we mostly think about the tonic-clonic version of this. We sometimes forget about absent seizures or myoclonic or atonic seizures. The special syndromes that we can also get are conditions like the Lennon-Gastaut syndrome and Dravet syndrome. The seizure threshold is something that we need to understand This is the level of brain excitability at which a seizure is likely to occur, and the seizure threshold varies quite distinctively between individuals. We can clearly see this with electroconvulsive therapy, where as we start low and go slow with energy levels, we can see that some individuals will experience the first seizure at low levels of energy, whereas other patients will have to have quite high amounts of energy before we see a seizure. The factors influencing the seizure threshold are genetic factors. These are often inherited conditions that affect neuronal excitability. Epigenetic factors, where the genetic or the underlying genetic conditions can be influenced. That could be stress or diet or other modifying or modifications of gene expression. And then obviously life stress differences. And this is more often than not things like brain injuries, strokes, malignancies, which can often lower the seizure threshold. The clinical importance is to understand these factors can guide personalized treatment approaches. So we know that different people with different levels of brain abnormalities will experience seizures at different levels and different stages. With a quick look at etiology, we can see that seizure-related disorders have got a wide array of causes. So, like we just touched on with the seizure threshold, we can see that there are genetic causes, and these often include channelopathies. What that means is that often some of the sodium, potassium, and calcium channels are not as robust as other people's, and this will cause a lower seizure threshold, and they will experience a seizure with lower stressor levels. For instance, children with pyrexia-related seizures. It can either also be developmental, for instance, congenital malformations, perinatal factors, traumatic brain injury, infections, metabolic disorders, substances, toxins, medications, cardiovascular accidents, neoplasms, and degenerative disorders. The phases of seizures are quite important. So, as you might remember, we get the pre-ictal phase, the ictal phase, the post-ictal phase, and then the interictal phase. And this then repeats to start with the pre-ictal phase. And these can range between days, weeks, and months. And the reason why this is important is because each phase can present with a different psychiatric manifestation, especially if we have or are dealing with a patient with focal or partial seizures. So with pre-ictal phases, we usually get vague symptoms like malaise, dysphoria, fatigue, and patients who have had seizure-related disorders for quite a while recognize this as early warning signs of an ictal phase. So with the ictal phase, it starts with the aura. So ictus means that they're already experiencing a seizure, and often, and this includes myself before I understood epilepsy quite well, thought that the aura was part of the pre-ictal phase, but it's actually part of the ictal phase. And this is where the classification system comes in, which we touched on a little bit earlier. And this is where we get focal aware and impaired aware seizures or generalized seizures. And there are multiple psychiatric manifestations we will touch on later. Then after the seizure has discontinued, we have the post-ictal phase. And then here we can have post-ictal delirium and post-ictal psychosis. And as time progresses, we go into the intra-ictal period. So this is between the ictal phase, and it can range from weeks to months when we start with the pre-ictal phase again. The intra-ictal phase also has various presentations, and they're usually pleomorphic, meaning that they can have various shapes and sizes, and this can either be mood or psychotic disorders. Just quickly touching on the anatomy. So if we have a cut through, we can see here, if we look at the prefrontal area and the occipital area, the deeper parts of the brain, especially the limbic system, can be affected as well. And this is where we get relatively weird and wonderful presentations of seizure-related disorders. If we look at a coronal, we can see the internal capsule. You can see the motor areas, but also the sensory areas. We just move a little bit deeper into this brain section. And we also can see the brainstem area, which we'll look into the next slide, which houses the reticular activating system. It is helpful to remember that the brain is not just a piece of grey jelly, but it is actually a very complex system of, if you can compare it to a computer, microchips and wiring. So the outer edges, or the grey matter, will be then billions and billions of microchips, and they're all interconnected to these wires, the white matter, and also the deeper structures will be neurons again. And together they form trillions of interconnections. We can see the complex nature of it. So it's quite important to remember this. If we look at a simple or more simple structured view, what's important, especially in focal seizures, is this area, the reticular activating system, which consists of the medulla oblongata, the pons, and the midbrain, which houses the serotonergic, dopaminergic, and noradrenergic neurons, which project upwards into the cortex through the thalamus. And basically the part of the brain that wakes you up. They make you conscious. From the thalamus downwards, we get projections that inhibits this process, and the GABAergic. And there's this very slightly balance on the knife tip between being awake and being asleep. And this is regulated by hypercretin or orexin. So if something damages or disrupts this area, this reticular activating system, that's when your consciousness starts shifting. And with focal seizures, this is evident, especially the focal impaired awareness seizures. So if we look at the epileptical phenomena and look specifically at focal aware or simple partial seizures in older terminology, let's say, for instance, we have a specific locus of pathology over here, and this is the extent or the area of the seizure. And we can see that it does not touch the reticular activating system, and therefore we will have a focal aware seizure or a simple partial seizure. So the symptom complexes can be different depending on which part of the brain it is situated in. Especially if it's a focal aware seizure in the prefrontal cortex, then the person will be aware of having difficulty in controlling specific urges, for instance, aggression or withdrawal, and so on and so forth. If it's in the motor cortex, then they will notice, for instance, a myoclonic movement of the hand, and they won't understand why this is happening because they have no control over that. If we look at ictal phenomena, focal unaware or complex partial seizures, we can see that this is the locus of the seizure, and then the extent of the seizure spreading all the way into the reticular activating system. And this will give very, very interesting pathology or behavioral changes, which we'll look into now. So if we look at the frontal lobe has the prefrontal area, it has the motor cortex area, it's got the Broca area, speech area. So depending on where this focal seizure is and how widespread it is, we will then have these specific changes. So if it's in the motor cortex, we will have myoclonic jerks, and this can be with or without a Jacksonian march. And just to remember, or as a reminder what that is, it starts off, say for instance, with the fingers, and it will slowly spread out into the forearm and then the upper arm. It can also be in the gaze area, and then we will have a fixed gaze away from the lesion. It can be in the Broca area, so we will have temporary expressive aphasia. And it can be in the prefrontal area, where we will have abrupt or fluctuant behavioral changes, fluctuant loss of executive functioning, and posturing or catatonic episodes. If we look at parietal lobe, this is quite uncommon, and 80% of them will get auras. They usually have abnormal sensations in the dermatin distribution, and they have formication. Note, it's an M. Formication is the feeling of creepy crawlers under the skin. Apraxia is also present in some cases. If we look at the occipital lobe, this is in about 5 to 7% of cases. It is often missed, and people have visual perceptual disturbances, which are usually simple, and each can range from colors, shapes, micropsia and macropsia, that is, seeing things smaller than they are or larger than they are. This can also spread into the temporal lobe because they're so adjacent to one another. If we look at the temporal lobe focal seizures, this is the most common, about 60% of cases. It is responsible for mimicking psychiatric disorders, or is mistaken for psychiatric disorders. Auras are common, and it's usually accompanied with things like epigastric discomfort, autonomic signs, and unpleasant emotions. Perceptual disturbances are quite common, and they can have simple hallucinations which involve smell, taste, and hearing. They get disturbances in memory. Often it is déjà vu or jamais vu. And they get disturbances in mood with acute onset fear or a depressed feeling. And usually there's gelastic laughter or crying, which means that they can laugh or cry out of the blue, but they don't understand why they're doing that because they don't feel a specific emotion while that's happening. If it affects the Wernicke area, there will be episodic receptive aphasia. And what's important to know is that the EEG is usually normal due to the anatomical structure of the temporal lobe because of the uncus. So if we look at post-ictal phenomena, as I stated earlier, we get post-ictal delirium and we get post-ictal psychosis. The main difference between the two is that with post-ictal delirium there is immediate onset, and this can last from minutes to hours, and it usually entails confusion, disorientation, irritability, and fluctuant consciousness. It is often confused with post-ictal psychosis or other psychiatric conditions. This is an important one, especially in older people, because often they have delirium, and we don't understand why, because the urine and tox screen and blood screens are normal. But usually seizures are, take place in the early parts of the morning, which is often not witnessed. Post-ictal psychosis, how it differs from post-ictal delirium, is that there's an episode of lucidity following the ictal phase. So, they wake up, they're generally fine. Sometimes they can have a very short delirium, then with a lucid period, and then all of a sudden they start becoming quite unwell. Common is temporal lobe type of seizure activity that can cause this. It can last between 16 hours and 18 days, roughly. And it's important to exclude convulsive status epilepticus or partialis continua. So often what can happen is they can move in and out of partial seizure states, especially if they're suboptimally treated. So the management is best to gain control of the epilepsy, especially if it's partialis continua. And this can be done with antiepileptics, starting with benzodiazepines and then moving to antiepileptics. But sometimes, if it becomes too difficult to treat it, then one needs to probably consider antipsychotics. But just remember that antipsychotics can lower your seizure threshold. Moving to interictal phenomena, what is quite prevalent is depressive disorders, and this can be from 17 to 21%. They're usually atypical, pleomorphic, and this usually entails a chronic dysthymia with short episodes of euthymia. They're quite difficult to treat as well. Sometimes they can have other symptom complexes like irritability, avolition, insomnia, and so on and so forth. Sometimes there can be brief exchanges with euphoria, and this can often be mistaken for bipolar disorder. And if you remember the DSM criteria, there must not be another medical condition that can better explain the symptom complex that you are witnessing. Suicide risk is higher in those without epilepsy. Management can be controversial as not enough studies are done yet. Usually it is said that tricyclists should be avoided because it can lower your seizure threshold. So your simple SSRIs and SNRIs will probably be best. Anxiety disorders also tend to be more agoraphobia-like, and then also conditions that mimic generalized anxiety disorder. Then psychotic disorders are the interesting ones. They're very schizophrenia-like. They basically meet the DSM criteria except for the criterion of the general or other medical condition. It usually starts a few years after the diagnosis of the seizure onset, and it's usually in patients with long-standing, difficult to treat epilepsy with a sudden cessation in epileptic symptoms and forced normalization on their EEGs. So forced normalization means that the moment they become psychotic, their usually abnormal EEG looks normal. What's interesting then is when the psychosis suddenly stops, this forced normalization stops then and the EEG becomes abnormal again. It's quite an interesting phenomenon. So if we look specifically in older persons, as early in the presentation, there's a higher incidence, especially in those with central nervous system vasculopathy and progressive major neurocognitive disorders. Often the seizures are in the early hours of the morning due to diurnal variations in hormones, so they go unwitnessed. They can wake up with post-ictal delirium or later during the day develop a post-ictal psychosis, and this will seem to the staff as out of the blue. Often the post-ictal delirium is missed with the differential diagnosis or missed as part of the problem list if the urine and bloods appear clear, but they don't understand that this is a post-ictal delirium, and then immediately assume that it might be some kind of a psychotic condition. So because antipsychotics lower the seizure threshold and worsen the outcome, anti-seizure medication should be considered as the first option. So with management, it is important to ascertain that we don't have other underlying causes with the abrupt changes in behavior. So it's yet again very important to do bloods, urine analysis, making sure that there's no missed constipation and so on and so forth. Also, that is important, I often see are patients with liver dysfunction, which can lead to hepatic encephalopathy. So that is because the liver is suboptimally functioning, you will get abnormal protein metabolism with increased ammonia levels in the colon, and this will lead to hepatic encephalopathy with delirium symptoms. And an easy and a great way to treat this is with lactulose. So I would say that if you suspect that this might be a post-ictal delirium or one of the seizure-related disorder psychiatric manifestations, what I usually do is I switch the PRN benzodiazepine to a regular and monitor carefully and maybe up-titrate if necessary. If the behavior improves, then we cross-taper to an antiepileptic. So sodium valproate is an option, but it has quite an impact on the liver. Levetiracetam is favored by neurologists. I don't know why, except for that it's got limited liver metabolism, but it's notorious for behavioral changes. And I've often seen patients who, when they start with levetiracetam, can become quite irritable, short-tempered, and so forth. So pregabalin and gabapentin are probably better options, especially in older adults. And it also helps for other behavioral changes as well. These are also rapidly excreted by the kidneys, and thus they have limited liver impact, and they're relatively well tolerated in the age group, with the added mood and anxiety benefits as well, especially with pregabalin and generalized anxiety disorder. What's important is to know that EEGs are often unreliable as a special investigation. A comprehensive clinical evaluation remains the golden standard. So very good comprehensive history taking, collateral history taking, and also asking staff, especially night staff, to monitor them carefully. So it's best to get a CT, MRI scan, and so on and so forth, and do the bloods, just to make sure that we don't miss anything else. And with CT and MRI scan, and we can actually see what the cause of the new onset seizures could be if we make this diagnosis. And so here are the references, and there are some interesting extra reading material. For instance, with Arjun Sen and Benjamin Creighton. Creighton, I'm glad my surname's not Creighton. But these are very good articles. They recently published as well. So I would highly recommend those.